Um, like where from the ventricle do I think it's coming from?
Mm-hmm.
Um, it's up into three. I'm not sure, Dr. Pass.
Okay, so when we see that we're upwards in the inferior leads, that means it's coming towards the inferior leads, right?
Mm-hmm.
Because it's positive in them. So that means somewhere anterior or
Mm-hmm.
superior. And we see that it's a left bundle morphology. So these are RV outflow tract PVCs. Okay.
Okay.
All right. So patient is having RV outflow tract PVCs. So what do we think about that? Is that a good thing, a bad thing?
I think it's a better thing, but I don't remember why.
Okay. So you're right. In general, PVCs from the RV outflow tract are not very worrisome. They're a normal finding in many patients. But it is somewhat unusual, right, to have that many PVCs
Mm-hmm.
on a resting tracing. So how would you make yourself feel more comfortable about it? You talked about getting a Holter. What are you looking for on a Holter? I agree with that statement to get a Holter.
The burden of the percentage of times the patient is in this rhythm.
Okay, let's say he's in it 25% of the time.
Mm.
Is there anything else you're looking for on the Holter other than the burden?
If it ever converts into a different rhythm
What do you mean by that?
of like a VTAC
So
or
you mean if there's multiple beats in a row? Is that what you're
mm-hmm.
talking about? Yes.
Yes.
So if there are multiple beats in a row, that would be bad, um, because that would be VT. So yes, you would want to see that. Is there anything else you would see that would be reassuring or not reassuring?
Mm. I
So
mm-hmm.
what about with exercise? What if the patient is
Oh
exercising?
yes. Uh-huh. If it goes away with exercise, that would be reassuring. Or if it happens
Right,
less at a
right.
higher heart rate.
So generally speaking, when people have PVCs, if the ectopy becomes less frequent with exercise, we generally view that as a positive sign for being more safe. Um, but it's not a guarantee, but it's pretty reasonable. So oftentimes people would either do a Holter or you could do an exercise stress test. Most people would probably do both. Okay. Now, is there any other concern when somebody has PVCs from the RV outflow tract? Are there any other disorders that can affect the RV outflow tract that we would be concerned about? Hello?
Sorry, I'm thinking. This or no, I would be guessing.
So we'd be worried also about much less commonly. So the first thing to say is this is generally a very benign finding,
Mm-hmm.
very common to see in healthy patients. It's not normal, but it is not necessarily dangerous. Some people think that if your PVC burden exceeds a certain percentage of your total QRS complexes in a 24-hour period, that this could be associated with cardiomyopathy. I think in the adult world, 20 or 30% is sort of their golden rule. They feel that if you see more than that in an adult, the chances of developing a tachycardia-induced cardiomyopathy are high.
Mm-hmm.
That is not necessarily true in children. I've seen many children with 50% of burden without any cardiomyopathy associated with
Mm-hmm.
it. But in adults, that's certainly a concern. But generally speaking, if the burden isn't very high and it extinguishes with exercise and the patient is asymptomatic, we wouldn't necessarily do anything about this.
Mm-hmm.
But we would normally want to rule out arrhythmogenic right ventricular cardiomyopathy because patients with this disorder typically have ectopy from that area.
Mm-hmm.
Now, the thing to remember, though, is that people with ARVC in childhood don't usually have that many problems. In other words, the VT and the VF that you hear about in that is usually an adult phenomenon, not as much in pediatrics.
Mm-hmm.
But some people might consider doing an MRI in a patient like this, looking for signs of ARVC on the MRI. Hopefully, in the future, we'll have better testing for ARVC There's actually a potential immunological test that's being tested now for ARVC because some people believe it's an inflammatory disorder. Unclear, but the bottom line is the other reason to do a stress test is to just make sure you don't have catecholaminergic polymorphic VT, right? In a stress test, the classic finding is that when the heart rate exceeds about 120 to 130 in sinus tachycardia, one starts having lots of complex ectopy. So those would be the things you would look for if somebody, if you saw this. So generally what you would do is you would do a Holter or a Zio or a Barty device for a day or two just to see what the burden of tachycardia is, to make sure you're not seeing runs of it. And really the indications to ablate or treat this, so when you see this, the natural inclination is to treat it, right? No one likes to see this much ectopy, but really medical therapy for this is generally poor. And so the only indications generally to treat this are, assuming it's a benign form of RV outflow PVCs, if the patient is symptomatic. Some patients actually feel them and it bothers them a great deal. But I will tell you it is rare in my experience that patients feel these. And the other is if you're seeing a cardiomyopathy developing from these. And since both of those are very unusual to be seen, usually this does not need to be treated. But if it is bothering them or if they have a very large burden, people would typically ablate this. And ablation for this is quite effective. So, okay, let's move along.
Dr. Pass, if you treat it, what would you treat it with?
Well, normally people, Perna, you're in your car, I see. Normally we would use something like a beta blocker, but I'll be honest in saying beta blockers usually are not very effective. You could try a calcium channel blocker, that might be effective. If either of those failed, probably the next drug people would try would be something like sotalol, because amiodarone might work, but obviously it's not a good long-term solution for any arrhythmia because of the long-term side effects associated with its use. Okay. All right. I think I see Simone Javeri on the line. Good morning, Simone. How are you?
Good morning, Dr. Pass. Good.
I think this is your final EP conference of all of your entire lifetime, isn't it?
Potentially.
Oh my gosh. Well, congratulations.
No pressure to get this right.
That's okay. Well, we had to ask you a marginally difficult question. So this is a tracing of a patient who is being ventricular paced during an EP study. We see that these are the five surface electrocardiograms. Ablation catheter is in the heart. We have distal, his, mid, and proximal, and then we're going from proximal to distal in the coronary sinus. And then here's the right ventricular apex pacing the heart. That's why it says S1. I think we're pacing at about cycle length 500, which is a rate, of course, of 120. And what's happening when we give intravenous adenosine at 12 milligrams?
Okay, so we're ventricular pacing. I see ventricular capture, and I'm seeing in the initial beats, I am seeing in the distal CS, there's no right atrial lead, right? No. So in the distal CS, I think I'm seeing an A after the V. As well as in the proximal CS. I don't see it as well in the...
I'm just listening to a lecture real quick.
So the first...
Afterwards, or is it, you need me to look at it now?
You see VA conduction. So you see retrograde VA conduction.
I agree with that statement.
And I don't see it. I'm trying to look for a change with adenosine, but I don't really see...
Yes.
I don't
Keep talking.
So I guess it's a non-adenosine sensitive VA conduction, which could be indicative of a pathway.
That's exactly right. So very good. So patients who have accessory pathways in general are not adenosine sensitive. And so when you give one of the proofs during an EP study that a patient has an accessory pathway is to pace the ventricle and look to see if there is ventricular-atrial conduction block in the setting of adenosine. So generally speaking, AV nodes are adenosine sensitive and accessory pathways are not adenosine sensitive. So in this case, as you rightly pointed out, there is ventricular-atrial conduction on every single beat, and there is no change in that throughout the tracing. See, this is an A in the high right atrium with the ablation catheter or somewhere in the atrium. And we see there's a V pace spike A, V pace spike A, V pace spike A, and so on and so forth. And as you also pointed out in the coronary sinus pairs, there is also a VA continuation. Notice that the pattern of the V's and the A's are not changing despite giving a very high dose of IV adenosine. And in fact, the other thing that's interesting is that the distal CSA is basically on time with the coronary sinus A, suggesting that there may be a pathway here. You might ask the question, why are they sort of similar in time? It's probably because the patient is young and has good retrograde AV nodal conduction. So they're almost, similar timing because remember the proximal coronary sinus is much closer to the AV node obviously than the distal CS. But the bottom line is that this would be considered confirmatory of the presence of an accessory pathway. Okay. One thing I should mention though, which I usually do in these circumstances, is that some pathways are adenosine sensitive. So in other words, if we give IV adenosine and the pathway block, and there is block, it doesn't definitively mean you don't have a pathway. There are rare accessory pathways that are adenosine sensitive, but the general rule of thumb, the rule to know for your boards, as it were, is that accessory pathways are generally adenosine insensitive. AV nodes are adenosine sensitive. Okay. So Simone, very good.
Thank you, Dr.
Congratulations. This is your last EP question and you got it right. So you can go into imaging knowing that you always gave up on a career in electrophysiology, a promising career in electrophysiology. So good job.
Thank you, Dr.
Okay, so this is a 2-year-old female in the emergency department for a possible prescription drug ingestion. And let me see who I want to ask today. I think we'll ask Dr. Neha Luwalia, who I see is on the line. Was waiting patiently for our 7:12 start time today.
Good morning, Dr. Bass.
Good morning.
All right. So this is a 2-year-old. I'm just looking at the rhythm strip at the bottom in lead 2. And looks like the first and the second QRS look different. The second one has a short PR with like an upstroke, like a delta sort of wave. And then you have few sinus beats and then again that complex. So it looks like intermittent pre-excitation. And what's the question?
Well, first of all, what do you think? Does this have any relationship to the possible prescription drug ingestion?
So I guess if you're taking any sort of an AV blocking agent, then you can manifest your pathway, I guess.
That's possible, but really my point is that it generally should have no relation. This is essentially an incidental finding. But you're right. If the patient had taken a lot of verapamil or digoxin, it's possible that it might enhance accessory pathway conduction by causing slowing in the AV node conduction. The reason that seems unlikely from this particular tracing, right, is that the conducted beats that do not have pre-excitation have basically a normal PR interval.
Right.
Right. So what would you do now that you see? So this patient has, what do you want to know from the mother of this patient? So the patient stays in the hospital. Turns out the drug ingestion was untrue. Telemetry just continued to show this. What would you do with this patient? Can this patient be discharged from cardiology? What would be the next move, you think?
I think we'll need follow-up.
Why is that?
I guess we have evidence of an accessory pathway. So at some point when the kid is older, we can possibly think of ablation. But if there's intermittent pre-excitation, usually they say that it's not a high risk, although I don't think you can rule it out.
So why would intermittent pre-excitation be potentially a sign of not high risk?
So that that means that at higher heart rates, your pathway is not going to conduct. So it's not that robust. So then even if you get AFib, you're not going to rapidly conduct, and the risks of sudden death from that would be less.
That's right. And so the theory, as you were pointing out, is that if someone is intermittently pre-excited, the theory is that the pathway has a long effective refractory period, or ERP, because if it did not, then it should be conducting on all these sinus beats, right? So this is a rate of about 100 beats per minute, and we are not conducting 100%. But as you rightly pointed out, there are rare case reports in the literature showing that the presence of intermittent pre-excitation does not definitively rule out high risk. So although the general rule of thumb is that the presence of intermittent pre-excitation is a sign of a lower risk pathway, and that is probably generally true, we cannot hang our hat on it. And so that has to be tested more aggressively in the cath lab generally, or at least with a stress test. So generally what we would do in an asymptomatic 2-year-old is we would probably halter this patient, follow this patient occasionally, and when the child is old enough to easily participate in a stress test, we would see if the patient has loss of pre-excitation with elevated heart rates. If the patient were to lose pre-excitation entirely with elevated sinus rates, the present recommendations from AHA, Heart Rhythm Society, and ACC would suggest that the patient does not need further follow-up in the absence of symptoms. But certainly we would tell a family of a patient like this that it is very possible that they will have tachycardia in the future. So, as I often joke in these cases, I tell patients, don't lose my card. You might still need it later on. Okay. Why don't we move on to the next slide? And I think I saw Namrita Mazumdar also in her, I believe this could be your last EP conference as well. Isn't that right?
Yeah.
No? Okay.
I said, yeah, but I don't know.
I mean, I will mention to you that despite the fact that you're going into practice, you are always welcome to come to our conference virtually every week on Monday morning. I'm sure you'll have nothing better to do then.
Oh, it's still going to be virtual? That'd be nice.
Well, I see no obvious reason not to keep it up this way. Neha was saying she enjoyed going to this in her pajamas, so we'll see if we can keep this up. So anyway, this is a 40-year-old male with a history of heart surgery at 3 who had a mustard operation. And what do you think is going on here?
Okay, so it's a very slow rhythm. So it's about 300, like 50 beats per minute.
Mm-hmm.
And then it changes from narrow complex to wide complex.
Well, is it really changing though?
Yeah, it's true. It's still pretty wide.
Like look at lead 2 on the bottom, the rhythm strip. I think it would be fair to say that QRS is not changing, right?
Right.
Okay. But I do agree with you. It is a wide complex. That's true.
And you see the PR interval in lead 2 is prolonging.
Mm-hmm.
So this is like first degree heart block.
Is it? Look at the rhythm strip. So let's look at the P waves here. So here's a P wave, right?
Mhm.
Do you think this P wave is conducting to this QRS? This PR is very, very
No.
short,
Yeah,
right?
it's short. Yeah.
Takes at least 150 milliseconds in an adult to go from the sinus node to the AV node and ventricle. So these are probably isosynchronous beats in the atrium and the ventricle. Then this beat here, this is the next sinus beat, is if it's conducting with a very long PR interval.
Yeah.
And then this beat here, right, this is the next sinus beat, doesn't seem to be conducting at all, unless, of course, you're implying that it's conducting with a PR interval of, 700 milliseconds. And so, and then here we don't see a P wave at all. So the other thing to notice is that the R to R interval is pretty fixed, right? Like
Yeah.
this P wave, for example, is coming so long after this QRS, you would expect that this would conduct. Don't you agree?
Yeah. So this is complete heart block because
Right. Right. So this is right. So this is a child or an adult now, ACHD patient, who has postoperative complete heart block following a mustard operation, presumably many years before. So again, when you're looking for complete heart block, one of the great clues is the RR interval. So you were fooled initially because you saw this P wave that seemed to be
Yeah.
conducting with a long PR interval. But then if you look carefully, like this P wave is not coming in so late, so short after the last QRS that it should not conduct. In a normal person with normal AV conduction, this P wave should have conducted because this is only a rate of about 120 or so, right? And it's not conducting at all. So there's no variability. This P wave, right, should have conducted. This QRS should have been earlier, but it does not. So this patient is in complete heart block with a wide QRS escape rhythm. And so the other thing that's noteworthy is that the sinus node is also diseased in this patient. First of all, the sinus rate is very slow. And second of all, we have complete absence of a sinus beat here. So this patient has sinus node dysfunction as well, which is very common in people who've had a mustard operation or ascending. Anybody with an atrial level switch are very commonly have sinus node dysfunction. So you don't see these patients as often, but in the ACHD clinics, there are tons of these patients. So it's actually very, very rare for a 40-year-old mustard patient to not have a pacemaker. There are multiple studies, the first of which was by Connie Hayes at Columbia in the early 1980s, showing that by about 20 years after a mustard or a stenting, only a handful of patients, probably less than 10%, are still in sinus rhythm with a normal sinus rate. But this is not just sinus dysfunction, but also AV block. And so what would your recommendation be if this patient came into your clinic out on Long Island in 2 weeks?
So we'll have to do a Holter to make sure there's no higher degree AV block. Well, it's already complete heart, but just do a Holter just to make sure, see how long he's in it.
Okay.
And how low his heart rate goes, like if it's below 50.
Okay. But, okay. So now, does it matter, though, if it goes below 50 or not? Because this patient has had heart surgery.
Right. It doesn't really matter in him.
So if you remember, the 50 you're referencing is the rate that the AHA, ACC, and HRS says is if you have congenital complete heart block, what is the lowest with a narrow QRS escape beat in an asymptomatic patient? That's generally the line in the sand that they say you should be strongly considering a pacemaker. I believe that's a 2A indication for a pacemaker. But this patient had congenital heart surgery. So we think about them very, very differently, right? If you've had congenital heart surgery. So in this patient, we would recommend a pacemaker. Why would we recommend a pacemaker in this patient?
If he's been in heart block, usually they can post-op, we do wait like 2 weeks and they stay in heart block, you put a pacemaker in.
Right, but he had his surgery at age 3 and he's now 40.
Well, if he's in heart block, it's likely not going to come out of a heart block, so you need to keep that in to prevent sudden death. And
That's right. So we believe that the risk of sudden death in patients who have postoperative complete heart block is not insignificant. I think we've talked a number of times about this very old study from the early 1970s where at the Mayo Clinic, they took patients after open heart surgery, and half the patients got pacemakers who had complete heart block following congenital heart surgery and half did not. And it turns out that if you did not get a pacemaker, your mortality was, I think, like 50% at 1 year. It's very, very high. So you always want to pace a patient if they have prolonged complete heart block following heart surgery. Someone who's 37 years after surgery, that would be a prolonged complete heart block. So in the absence of a cause of it, I guess if his patient had normal conduction for 37 years and came in like this, you'd want to rule out the causes of heart block that are not congenital heart related. So you would do thyroid studies, you would do a Lyme study, you would do a SED rate or a CRP to see if there's any inflammatory disease going on. But the likelihood is that those will all be normal and patient will probably need a pacemaker. So what kind of pacemaker would you put in? Would you put a single chamber or a dual chamber in this patient?
do a dual chamber.
Okay, I agree with that. Why?
Because in complete heart block, we have to synchronize the A and the V's because they're all dissociated.
Right. So there's a couple of reasons you would want dual chamber here. First of all, you would want AV synchrony. And one of the main reasons you would want AV synchrony is because people who have bad heart function are particularly dependent on AV synchrony. If you don't have AV synchrony, so AV synchrony in a person who has a normal ejection fraction only adds about maybe 5 or 10% to your cardiac output, which is why when we pace patients after congenital heart surgery in a VVI fashion, the vast majority are perfectly fine because they usually have good heart function. But if you take someone who has bad heart function, the impact of AV synchrony can increase cardiac output as much as 25 or even 30%. It could be quite substantial to have AV synchrony. And we know that almost all mustard patients at age 40 have at least moderate ventricular dysfunction because, as we know, the right ventricle in a mustard is the systemic ventricle, and systemic right ventricles over long periods of time generally have a bad track record in terms of heart function. It's rare to find a patient after a mustard that far out who has normal heart function. So V pacing alone would not be a good idea. And obviously, when someone has complete heart block, we can't A-pace them. The other benefit of a dual chamber pacemaker in this patient is that they have sinus node dysfunction. They have chronotropic incompetence, in this case on two bases, right? On the basis of heart block, but also on the basis of sinus node dysfunction. But once we put a pacemaker in, you could put the rate responsive feature on, and the patient would have AV synchrony and would have a more normal atrial rhythm or a more normal atrial rate, which would also improve cardiac output for a patient. So we would anticipate that a patient like this would feel markedly better with a dual chamber pacemaker and could also prevent sudden death for multiple reasons. So, okay, why don't we move on to our last tracing of the morning. This is a 3-year-old male with a history of a failed Fontan. He's now post-op day 5 following takedown, and he is having tachycardia. And I see Dr. Uzoma Obiaka of the Upper East Side of Manhattan here on the line. Hello, Uzo. How are you?
Good morning, Dr. Paz.
What do you think we're looking at here?
So in the first third of the strip, the patient seems to be in his baseline rhythm, seems to be sinus with variability in the heart rate. And
Mhm.
then in the third, in the middle section, he has like a sudden increase in the heart rate, which is sustained,
Mhm.
with a heart rate of about 160 in a patient who had a fontan likely to be flutter,
That's
or
right.
IRT. And then in the last part of the rhythm, the heart rate is at 100 and it's like a flat line. So it looks like he's being paced.
Mhm. Mhm. Well, that's exactly right. So that's an excellent interpretation, Uzo. Very, very good. So this patient does have a sudden onset of a tachycardia. And so when you see a sudden onset and a sudden offset, usually that is consistent with a reentrant mechanism of tachycardia, as opposed to an automatic rhythm where we would normally see a more gradual increase in the heart rate. So that, and Fontan patients are more common to have IART or atrial reentrant tachycardia. And very astutely, you noticed that after the tachycardia, the patient has a very straight line of heart rate. It's really not varying at all. And this is not a physiological peering tracing of heart rate. When you see a line on the monitor review chart that has such a straight line as this, virtually 100% of the time, this is a sign of an electronic pacemaker. So somebody has clearly turned on the pacemaker at either 95 or 100 beats per minute following this. Why would you pace somebody like this after an episode of atrial flutter? Why do you think the doctors did that?
Mm.
Well, the reason is probably because, well, what induces IART? It's typically atrial ectopy, right? That
Yeah.
induces reentrant arrhythmia. So if you're pacing the atrium consistently at a rate, at one rate, the likelihood of a PAC entering it and causing tachycardia is going to be lower. There's quite a bit of evidence that consistent atrial pacing can reduce the incidence of IART. I myself have a patient, used to be at who, when I was still working at Montefiore, a Fontan patient, just like this. He interestingly was in junctional rhythm with actually a normal rate, about 70, but his pacemaker broke and actually developed an infection and it had to be removed. And so he lost his atrial pacing, and we naturally assumed he would be fine, at least temporarily, because his heart rate was in the 70s. But the moment that he stopped being apaced, he started to have IART. And when he would go into IART, he would have terrible hemodynamics, even though his heart rate in IART was only about 130. So it happened so many times that I had to emergently take him to the cardiac cath lab to place a temporary atrial pacing wire on him, and then ultimately we placed a new dual chamber pacemaker on him. And again, since the time that we have placed this atrial lead, he has never again had IART, even though he had about 6 episodes in a period of about 3 or 4 days until we were able to put in this dual chamber pacemaker, new dual chamber pacemaker in him. So this is an example of the doctors in the ICU using the presence of a consistent, continuous paced atrial rhythm to try and use that as a preventative or essentially an antiarrhythmic maneuver to prevent IART in the postoperative period. Perhaps they were loading with a medication at that point. So we're at 7:50 now. I think we're going to call it a day. I apologize for having to get started a little late. I had to go to a meeting, a virtual meeting before the virtual meeting that was called very late on Friday. So I hope everybody is well. Have a wonderful week. Thank you for joining. For those of us at Sinai, I look forward to seeing you in just 10 minutes at Sinai. Thank you very much, and we will speak soon. Have a great day.
Thank you.
Bye-bye.
Thank you.
Thank you, Dr. Paz.
Thank you.
Thanks.